information is Hello, good afternoon. Hello. Can you hear us? Hello, good afternoon. That's great. This one? No, it's coordinating. Good afternoon, everyone. Thank you very much for giving us a chance to take part in this very important conference. And I'm speaking from London, and I've got one of my trainees with me. My name is Dr. Mlawa. I'm a physician in diabetes and endocrine based in Queen's Hospital, Romford, in East London.
I'm Humagni. I'm one of Dr. Malawa's trainee. Good afternoon, everyone. Nice to meet you.
So in today's presentation, we're going to talk about mental health and diabetes. And to start with, we will talk about few case series we've seen in our trust. We know that the second generation antipsychotics are the medication which are better in terms of managing patients with mental health problems such as bipolar disorder, schizophrenia, and they are very effective. But there are a lot of side effects. And one of them is the cause of hyperglycemia or unmasking pre-existing diabetes, or people with diabetes become worse because of that. So I'll leave to Dr. Magni to present the 4 case series. Then I'll come and go through the discussion together.
Okay, so I will speak about the 4 cases we are going to discuss here. First is about a 71-year-old lady who was admitted in 2015. So basically, she was diagnosed with DKA, and when we went through her history, it was found that one of the medications she was on was olanzapine. Now, the second case is about a patient who was ultimately found to be diagnosed with HHS. And again, in her past medical history and medicine history, a common thing was found that she was being treated with another antipsychotic named amisulpride. Then let's go to the third case. This is again another lady, but 39-year-old. She was having a diagnosis of mixed case of DKA and HHS. She was having a mixed case of DKA and HHS, and in her medication history, we found that she was being treated with olanzapine again. Okay, then we will be going into the fourth case. This is again a 37-year-old lady, but her diagnosis again was similar to the third case, like a mixed case of HHS and DKA. And again, in the medication history, there were 2 drugs found, olanzapine and sulpiride. So we can see that all were antipsychotic drugs.
So looking at this, the 4 cases, we know that these patients were on antipsychotics for different times of duration. And this slide just trying to summarize, it tells you how long the patient has been on antipsychotics. Some of them, they've been on antipsychotics for 8 years, some of them for 12 years. Some of the patients were on 4 months, and one patient was on antipsychotics for 2 years. And if you look at the presentation, some of them they had acidosis, they had very high sugar levels, and some of them, they had ketones. So it's a mixed picture of cases with DKA and HHS. And And if you look at these cases, you get the common denominator. Patient 1, patient 2, patient 3, and patient 4. All 4 patients, they were on some sort of second generation antipsychotics. I've just told you that second generation antipsychotics are very good medication in terms of managing mental health problems, including schizophrenia and bipolar disorder. But we've just seen that it can cause side effects. And one of the side effects is hyperglycemia or unmasking existing diabetes. So, and in terms of people with mental health problems, in patients with mental health problems, the prevalence of diabetes is higher compared to background population. It's about 10 to 15% compared to background population. But also, having mental health problems, you're at risk of getting diabetes up to 3-fold. And we know that patients with mental health problems, they live unhealthy lifestyle, they don't exercise, they eat junky food, and therefore they're at risk of getting other metabolic syndrome, such as a cardiovascular disease, hypertension, and obesity. And also we know that patients with mental health problems, they live less longer compared to background population by 10 to 15 years. So these are patients, it's a very special group of patients who if they've got problems, including chronic conditions such as diabetes, we need to make sure that we manage their diabetes well. But in order to do so, you need to make sure that you manage their mental health problems. And therefore, that comes the role of working in a team, not only working in different isolated teams. So if you look at patients with mental health problems, some of them, they've got eating disorders. Some of them, they suffer from anxiety, and being anxious, you increase the level of the so-called counter-regulatory hormones, namely glucagon, cortisol, and adrenaline, and that makes hyperglycemia worse. So in terms of the mechanism by which these antipsychotics causes hyperglycemia, it's postulated that they cause hypoglycemia by different mechanisms. But from the current available evidence, we know that olanzapine and the clozapine they're more likely to cause hyperglycemia simply because they cause the more weight gain. I'm going to share some of the slides to try and clarify this. So one of the mechanisms which has been postulated is the fact that the antipsychotic medication increases appetite, and with that, the patient with mental health problems taking antipsychotic medication, they eat more. When they eat more, they gain weight. And by gaining weight, you increase insulin resistance and therefore most likely type 2 diabetes. So one of the pathophysiology of type 2 diabetes is about insulin resistance, and being overweight is a contributing factor to developing diabetes. But also, there's a possibility that some of these medications can cause the so-called direct beta cell toxicity, leading to pancreatitis and therefore hyperglycemia and therefore diabetes. These patients with mental health problems, I've just told you that they've got other metabolic problems such as obesity, and therefore these medications somehow they increase insulin resistance and or reduce insulin sensitivity, contributing to hyperglycemia. Professor Holt and the colleagues, they have written previously saying that by having mental health problems such as schizophrenia, you are almost 2 to 3-fold increased risk of getting diabetes. The mechanism is unknown. And if you look at these medications, which are antipsychotics, I see a lot of patients in my endocrine clinic, when the patient taking antipsychotics, most antipsychotics cause hyperlactin. So these patients, they've got hyperlactin. Are we saying that by having hyperlactin, it interferes with glucose metabolism and therefore causing hyperglycemia? So these are just postulated mechanisms by which these medications can cause hyperglycemia. When we talk about other risk factors, I work in London. London is a cosmopolitan city. You get the population from all over the world. So those of ethnic minority, they are more likely to have hyperglycemia and therefore also having mental health problems. If you've got a family of personal history of diabetes, you are most likely to have diabetes. I'll give you an example. If the father and the mother are type 2 diabetes, the chance of children to get type 2 diabetes is about 75%. So you can't change your genetics, you can't change your parents unless you are adopted. But also coming from London, I live in London. London is a cosmopolitan city, but it has got areas with poverty, and therefore those patients with low social economic status, or those patients with areas which there's poverty, they are more likely to have hyperglycemia or diabetes because they eat poor diet, there's no exercise, and because of that, it contributes to diabetes. And most patients with mental health problems, at least from this part of the world where I come from, they come from disadvantages or social economic deprivation areas. So this slide just tells you it's a meta-analysis by Allison and colleagues, and they looked at different antipsychotics and the way it causes weight gain. By looking at this, you can see that olanzapine and clozapine causes the most weight gain, and therefore they are more likely to cause hyperglycemia. Remember, for type 2 diabetes, being obese, you increase insulin resistance, and therefore you reduce insulin sensitivity, and you're at risk of getting hyperglycemia or type 2 diabetes. And this slide just tells you, it's just the same slide, but in ascending order in terms of how these antipsychotics can cause weight gain. And we know that clozapine and olanzapine are at the top of the pyramid simply because they cause the more weight gain, and therefore the risk of causing hyperglycemia or diabetes. So in terms of managing these patients, we've shared the 4 cases which are patients I've seen in my hospital, in my practice, in my setting. But managing these patients are very difficult. One of the patients which my colleague had just presented was a lady who came with DKA. She was sent home on insulin, but because of mental health problems, she was not taking her medication, including insulin. She was readmitted, and she had to spend almost 2 months in hospital because without managing their mental health problems, these patients are more likely to be non-compliant to a lot of their medications, including medication for diabetes. So for that patient, we have to involve not only the diabetes team, but we have to work together with a psychiatric team. And with that support, the patient was able to go home, and they are having ongoing support in the community. I cannot insist enough in terms of the role of the multidisciplinary team, the so-called MDT, in managing these patients who are very small population, but they are very special patients, and therefore they have to get the best deal in terms of their care. So for this patient, we work together, at least in our setting, this part of East London where I work, we work together when we do a diabetes clinic for a patient with mental health problems. We always work together alongside the mental health team. So I've got a psychiatrist alongside me, and we also involve psychologists. So the role of working in the team is important to get better patient care and outcome, and the long-term prognosis in terms of their lifespan. So based on that, we have got the so-called National Institute for Clinical Excellence. That's nice from UK, but also we get guidelines from Diabetes UK and American Diabetes Association. The proposition is, if a patient is diagnosed with mental health problems, at baseline, before you start their medication, you check their HbA1c, you check their fasting glucose, then you follow up 3 months after. Then after that, it'll be once a year, you check their HbA1c to make sure that they don't develop hyperglycemia. Because we've known that this medication can cause hyperglycemia, and therefore at least once a year, this patient will have some blood tests, but on those blood tests, you include HbA1c to make sure that these patients are not developing whether type 1 or type 2 diabetes. So this slide is just a summary in terms of when can someone be, how long someone needs to be on medication to develop diabetes. It's not time dependent, it's variable, but based on my own experience in terms of this patient, which I chose, the 4 cases, some of the patients were on this medication only for 4 months, some of them were on this medication for 2 years, some of them were on this medication up to 12 years. So what will be the contributing factor if they had other risk factors such as obesity, whether they've got hypertension, they've got hyperlipidemia, that may be contributed to trigger and unmask their diabetes. So in summary, we've talked about the role of managing mental health patients, but in a team to make sure that we get better outcome for these patients and a better prognosis long term. These are complex patients, and I cannot insist enough in terms of the role of the so-called MDT in managing these patients. So this is an example in terms of best practice for this patient, that working in a team will be the best way of making sure that you offer high quality care to the patient and therefore better outcome long term. Thank you very much. I'm happy to take any questions.
Okay, yeah, thank you, all the presenters. And the presenters who are here around, they can come now in front so that you can spend a few minutes to have, like 20 minutes for the discussion. You are welcome. Gideon, can you stop sharing?
Thank you.
So now the floor is open for discussion. You can raise up your hand and we will reach you with microphone. At the back.
Good afternoon, everyone. I'm Heaven Light from NSK Hospital. I'll be having 3 questions. And the first 2 questions will be going to Dr. Innocent. And the first question will go to the first presenter. So among the 2 questions that I have, the first one is, you told us the patient was admitted at ICU and being treated as a severe C19 patient, which means anticoagulant being one of the medication that the patient was being managed with. So my question is, why do you think she developed severe thromboembolism, just from your perspective as a doctor? And my second question is, what do you comment to the people that are taking anticoagulants randomly as a prophylaxis for C19? And my first question that goes to the first presenter is, you told us the main barrier was type. Like they don't have time to go to hospital. But then you said from your solution that we need to educate them. How can we educate them while they still don't have time to go to the hospital? Where will they get time to get the education?
Yes, you are welcome for the response. Then.
Thank you, Dr. Heavenlight, for a wonderful question. Apparently, it is a question that I anticipated, and I should have explained it before during the presentation, but due to limited time. But in short is, from the pathophysiology of COVID-19, still literatures and studies have been ongoing. But recent studies are saying that when a patient or when someone is infected with COVID-19, one of the worst cases scenarios is that there is a release of inflammatory mediators, the interleukins, the tumor necrosis factor, and those are responsible for releasing an increase in pro-coagulation factors and decreasing in pro-anticoagulant factors. And that is why majority of COVID-19 patients have an elevated D-dimers. This is due to the cascade of pro-coagulation factors are increased, and those receptors that are involved to decrease the anticoagulants are in low amount. And that is why majority of COVID-19 have elevated D-dimers and mostly end up with a fatal thromboembolism. And it's not one, we have a lot of patients. That is just among the cases that we chose to present. And that is why we put more emphasis to people suffering with NCDs and diabetic, that they are at more risk of fatal complications or critical COVID or severe COVID-19. And coming to your second question, what are my recommendations for people taking oral anticoagulants over the table or without prescription? Well, I would recommend not to do so. I would recommend if you think you have COVID-19 or if you think you have symptoms of COVID-19, you should seek medical care and be investigated thoroughly. And upon investigations, once you're noted maybe with elevated D-dimers or signs or features of thrombotic events, then it's okay to be started on antithromboembolics, but over the counter or not prescribed anticoagulants, I wouldn't recommend. I hope I've answered your questions.
Okay, first presenter someone.
Okay. Okay, thank you. Thank you for a very good question. I think you might have heard about this. I did not say that they did not have time to go for treatment. Rather, I said they do not have time to go for enrollment to get ICHF insurance. So if somebody is sick or somebody has got an accident, cannot refuse or neglect or reject to go into the hospital. Obviously, this one will go. So what I said is that they did not have enough time. They did not have time, or they are not willing to go for enrollment. So that is another case. Going to the hospital, there's no option. I just said that they did not have enough time because they are so busy. Sometimes they work overnight, and so they do not have enough time, or they do not spare time for going to get enrolled. Hope that's okay.
Excuse me. Sorry, one thing to add on, I just forgot. Concerning the thromboembolism, a study, I can't remember, but from someone from Ireland, revealed that you don't have to take oral anticoagulants. Exercise are also enough anticoagulants, yeah? So if you think, or if you suspect yourself that maybe you have COVID-19 and you're in a worry of thromboembolic events, doing exercise where there is an enormous amount of blood circulating in the body is enough anticoagulation in the body. Thank you so much.
Thank you. I can see someone has a question from the back.
Yes, thank you very much. Actually, my concern is going to be on the issue of a health insurance fund. From the discussion of yesterday, we heard that it's only 4% of the health services. It's only 4% of health services consumers in Tanzania who have got the health insurance cards. I mean, they have already been registered for health insurance. That's something actually which seems to be a very problematic issue. And that's why the presenter who have presented concerning the health insurance issues, he has also said that there are so many clients who have been complaining that they don't like to be enrolled for health insurance because it doesn't cover in many health services issues, including NCDs. And that is something which caused by the low amount of the fund which is collected, simply because the contributors of that fund are very much few. You can imagine only 4% of the health consumers among the clients who are consuming the health services in Tanzania. So my only concern, since the policymakers are here, I want to make the emphasis to them that it has now reached the time for making this issue be actually, we should organize some policies to make sure Tanzanians contribute something in health insurance, like how we are doing in other areas. As you can imagine, and that we are collecting the money for houses, I mean the revenue for houses. We have decided to create different laws for collecting money in that area. And we have again succeeded to collect some extra money in mobile transaction charges. So we should use the same way in making sure that we enforce, if not in creating some laws of making sure we create some enforcement whereby all Tanzanians should contribute. By so doing, we shall manage to create a sustainable plan of including different health services in health insurance system. But otherwise, if we shall keep on singing the songs, maybe just promoting education without putting enforcements, we shall never succeed on this area. We need to create the laws now. Thank you very much. It was the contribution. Thank you.
Thank you very much for the good contribution on how we should go far, thinking of universal healthcare coverage and insurance, and how we should think of a mechanism to reinforce and get revenue collection, which might contribute in these services within the country. Yeah. Anyone has, yes, Karibu.
Thank you very much, all presenters, for very nice presentation that you have shared. Mine goes to KSMC. Basically, on the data, they say 1/3 of the patient with the atrial fibrillation died within 30 days. At the same time, big numbers where they had complication of developing stroke. So I just wanted to know, just to understand from the, from the perspective, like which intervention do we put in place, like at the KSMC? Are those deaths could be avoided if you had some facilities in terms of equipment and other things, or expertise or personnel, or they were, that's one. And secondly, are those deaths occurred within the hospital or they were outside the hospital? That's one. And then to my colleague who presented on ICHF, yes, from the methodology that you did, basically I saw that you collected information from the borders, but I didn't hear very well if you really triangulate the information from the key informants. I know if you did it in the district, definitely we have the those DMOs and other people that would give you some information. Because I'm curious, because you say one of the barrier for them to access the ICHF card is for them to go to the office. For me, I know the border, they're a little bit mobile, to move from one place to another. That one is, I don't think that it should be a barrier. So did you really have triangulation with other key informants? That one. Thank you very much.
Do you want to chip in before they respond? Yes.
Yeah, thank you. Again, I would like to appreciate all the presenters. This is very informative and very useful information. So mine are just comments. One is on the fatal thrombolytic complication, that presentation. It's more than a year now. It's almost 2 years now since we had the first case of COVID in the country, and we've had enough experience in terms of managing COVID cases, which are coming with different presentations. So mine is really a request again to our tertiary facilities. This is just one case report. I think after all this time, we must have collected enough information, whether it's case series or whatever it is. It's an operational research or whatever it is. So I think it's high time now we document all this information that we have so that we can come up now with our own treatment and management guidelines within the country. Okay, so again, this is my plea to all the tertiary facilities. Yeah, that's where we believe that we can have the data, we can have the evidence in terms of informing our policies and practice. So I believe You have done that at, I don't know, at Mloganzila, but probably there's something else being done at KCMC, Bugando, etc., etc. It's high time now you as our expertise to document all this information and inform the government what could be the appropriate treatment protocols or guidelines as far as Tanzania is concerned. And for the atrial fibrillation study, that was very good. But as actually this again goes back to what I was saying, primary prevention is very important, as well as secondary prevention. You see, these are people just walked in a facility, yeah, with such symptoms that, you know, they're very general symptoms, but eventually we realized that they had AFibR. So I think this is a challenge all of us to see how best do we capacitate those facilities down there. These are people who could have gone to the health facilities maybe 3, 4 times, and they would just be told, you know, maybe this is just a simple pneumonia, or it's just a chest pain, or you did this and that, simply because one could not really connect the dots that this could be this or this could be that in a very simple language. So let's come up with a tool that will really be appropriate for primary healthcare. But again, the issue of referral, because we have 2 types of referral. We have the upward referral, the up referral, and the down referral. So I don't expect a tertiary facility, well, in terms of, if it's a study, fine, you can follow up. But if it's in terms of a general practice, the lower health facility can do that job because they're very close to the communities. So we could have our patients that are treated at tertiary level, and then maybe upon discharge, we discharge them through the primary health facility, which will be which will have the responsibility of following up these patients, you know, just to make sure that, just to observe if they develop any further complications or et cetera, et cetera. So let's establish, I mean, let's strengthen this link. I know there's this referral, but we are more of used to the upward referral, but we've forgotten completely the downward referral. We also need to strengthen this. For my brother who presented on ICHF, again, that was very good, because currently there are also some ongoing studies that are looking at what are the barriers, you know, that hinder people from joining health insurance schemes. There are different schemes. There are those in the private sector, in the public, but also in the community. So I think your study actually is one of those that will give, that has given a very important information in terms of, I understand NHIF are here, but also other people are here. This is very useful information for us to take on board, yeah, when we are designing these interventions in terms of increasing our enrollment within the ICHF, but also other insurance schemes. And well, there's a comment that came from the floor about enforcing, yeah, that, you know, enforcing, I think it's meant on ensuring that everybody is enrolled in one of the insurance schemes. I'm sure you must have heard about the current move on the universal health coverage. That's where we are going. Not everything actually will work out by using, I don't know, laws and what. Of course, they're very important, but we must also understand that our people, especially people in our communities, okay, they've been very naive when it comes to the importance of themselves enrolling in insurance schemes. You know, we have people who are at different levels of understanding, but also level of education, et cetera, et cetera. So the most important thing actually that the government thought they should start with is to educate the people. People need to understand first, why should they be enrolled in any scheme? Because if you're telling me that the issue is that, oh, sometimes when I get sick, maybe I might not have money. What if I have money? Yeah, there are people who have got money. If they get sick and you tell them to pay from their own pocket, they'll pay any amount of money that you want. But how many are they? And is that a good practice? So where we started was first to educate people. People should understand, why should they be enrolled in any insurance scheme? Why should they, you know, be assured of their treatment in case they fall sick? But the second thing now is what we are talking about, the UHC. And because these things are governed by laws and principles, etc., that's why we have tabled a special bill in the parliament. But again, if you table that bill, there are procedures that you have to follow, yeah, for it to be tabled in the parliament and to be enacted. So this is ongoing, and I just want to assure him that that's where we are going. So every Tanzanian in this country will have a way of ensuring him or herself. But we shouldn't forget, there are people in Tanzania who are very poor. They will not fit in any of the scheme. These also need to have assurance in terms of how they are going to access health services despite their socioeconomic status. And these are the ones that the government now will have to invest on. So this is work in progress. I just want to assure that it will happen and everybody will be included in a certain form of a insurance scheme. Thank you.
Yeah, thank you very, very much, Dr. for summarize and giving us a highlight of what is going on in improving the insurance related issues and what can be done in the community in relation to referrals and preventive measures, which are the most important, and empower or creating capacity in the lower levels to diagnose and manage these cases whenever they are referred back to be taken care. Yeah. For the two of you, if anyone has a response for the question, then we can wind up the session.
Okay, thank you. Thank you very much for your question. And about if we did triangulation and involve the policy implementers, including the local government authorities, I'd like to say that what we already did for the triangulation was to involve, because the first plan in our study was to do the IDIs only for the local women food vendors and the border driver. But on the way, we found that we could use also FGDs to confirm some of the issues that were not well responded in the IDIs. But for the case of involving the policymakers or the policy implementers, it is true that we did not go for this. But in our recommendation, in the main study, we also suggest that another study can be conducted to involve the care providers as well as the policy implementers so that we can get this sort kind of balance and have a one stand or one understanding. Thank you.
Well, I will respond to the first questions asked to me. I think there are two. Well, thank you. First of all, thank you so much for the questions. And I will start answering the second question, which was were the deaths of that one, the patients who died, whom were 5, was it from the ward or was it from home? So our study was a prospective observational study, and the deaths were reported after the phone calls. So the other question was what interventions could our facility possibly adopt in order to minimize the risk of the complications of AFib. So basically, as you have seen from my presentation, I reported that of the patients with AFib, only one of them was using anticoagulants. And basically, these patients who had AFib, they didn't know if they have AFib. So it was just a symptom score, and we called these patients after screening. So the first intervention that can be performed maybe is screening for the patients. But on the other hand, for the patients who are found to have the condition now, they can be on long-term medications like anticoagulants, because the risk of AFib, as we have seen in my presentation, 5 patients developed a stroke in the 30 days follow-up. So these will be baseline interventions that can be adopted, screening and the use of anticoagulants for the patients. But again, I will agree with Dr. I cannot recall the name, that we adapt the primary health care interventions, that for the patients whom are discharged with conditions, they can be referred through the community to the primary health care, and not only upgoing referrals. We can go down with the downgoing referrals. So I think I've tried to answer your questions. Thank you.
Yeah, thank you very much to all the presenters. Actually, we have 3 minutes to wind up, and I hope we have exhausted the time. We have a good discussion and input from the floor. I would like to take this opportunity to thank you all for your presentation and the time taken to prepare and come to this session. And also thanks to all the audience for being in this session, for active participation in asking and contributing. And I think this will be winding up our session because we have almost minutes to start another session so we can have time to stretch ourselves. Thank you very much.